Thank you so much. Hello, and welcome to the presentation titled Best Practices in Managing Influenza over Telemedicine. My name is Sarah Keller. I'm an Associate Professor of Infectious Diseases at the Johns Hopkins University School of Medicine, where I see patients in the hospital, in the clinic, and over telemedicine. I am one of the leaders of this antibiotic stewardship project, alongside my colleagues at NORC at the University of Chicago and Johns Hopkins University. Should you have additional questions after this webinar, please note the safety program's email address is safetyprogram4telemedicine@nrsc.org. We wanted to welcome all of you to this webinar. Some of you may be coming from practices where you see some patients in person and others virtually, and some of you might be coming from practices where you see all patients virtually. Thank you for joining us today. None of the presenters have any conflicts of interest relevant to this program. The faculty and planners or managers for the Postgraduate Institute for Medicine, Johns Hopkins University, AHRQ, and NORC also have nothing to disclose. In support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institute for Medicine is jointly accredited by the Accreditation Council for Continuing Medical Education, or ACCME, the Accreditation Council for Pharmacy Education, or ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. For physician continuing medical education, this live activity is designated for 1 AMA PRA Category 1 credit. This activity is designated for 1 AAPA Category 1 CME credits. For continuing nursing education, the maximum number of hours awarded is 1 contact hours, and this activity is designated for 1 IPCE credit. Successful completion of the CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC points, up to 1 practice assessment MOC points in the ABIM's Maintenance of Certification program, and up to 1 MOC points in the American Board of Pediatrics Maintenance of Certification program. We will be using a clinical case-based format to discuss the approach to managing influenza. By the end of this presentation, participants will be able to describe how to diagnose influenza in children and adults over telemedicine, understand when a patient presenting with symptoms of influenza to telemedicine may need to be seen in person, explain the role of antivirals in the treatment of influenza, describe symptomatic treatment of influenza for children and adults, and learn about recommendations for influenza vaccination for children and adults. We will use the 4 moments of antibiotic decision-making in telemedicine to orient ourselves as we go through today's presentation. Briefly, this framework consists of the following moments. Moment 1 is my patient an appropriate candidate for a telemedicine visit? Moment 2 is, does my patient have signs and symptoms indicating an infection that may require antibiotics? Is a diagnostic test needed? Moment 3 is, if antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? And finally, moment 4 is, what symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? Let's start with the case. You log into your telemedicine portal to see a 35-year-old man with no past medical history who reports 2 days of myalgias, subjective fevers, and cough. It is February, and he did not get his influenza vaccination this year. Let's start with moment 1, which again is my patient an appropriate candidate for a telemedicine visit? This moment identifies patients who likely should be referred for an in-person evaluation based on the clinical presentation. When evaluating a patient for influenza, the time of the year and the amount of circulating influenza are important to keep in mind. If it is a time of high prevalence of influenza, according to the CDC or your local health department, such as winter, your patient has already obtained a negative at-home COVID test, and the patient has common signs and symptoms of influenza, such as a fever with a non-productive cough or other respiratory symptoms, myalgia, headache, and often fevers, it is likely that the patient has influenza. Between 3% and 11% of all people in the United States develop symptomatic influenza in a typical season. Most have a mild illness that seems like a cold. However, a subset of people develop severe influenza. Compared to adults 65 and older, children younger than 18 are more than twice as likely to develop a symptomatic influenza virus infection. Influenza is responsible for up to 710,000 hospitalizations and up to 51,000 deaths in the United States yearly. The most common symptoms of influenza are fever, headache, sore throat, myalgias, cough, and rhinorrhea. An acute onset of a cough and a fever in the setting of a negative COVID test has a positive predictive value of at least 70% in adult outpatients when influenza is known to be circulating. This means that if influenza is in the community, 70% of adult patients coming in with acute onset cough and fever have influenza. You should suspect influenza in patients with typical symptoms if influenza is prevalent in the community. Although the influenza season is typically considered to start in October and end in May, moderate or high influenza activity generally begins in December and lasts through March. There is variation by state and by year, so it is useful to seek information about influenza prevalence for the area where the patient lives. This can be found on the Centers for Disease Control and Prevention's influenza website. You should also check state and local health department websites for more local data applicable to where the patient lives. Many patients with influenza can be evaluated over telemedicine. However, there are some patient groups that may require more workup and therefore may require an in-person visit. For example, some patients may be at high risk of worsening chronic medical conditions, which includes but is not limited to worsening of congestive heart failure, asthma exacerbation, and exacerbation of COPD. Other patients, such as those with immunocompromise or immunosuppression, those who are pregnant, those with morbid obesity, those living in chronic care facilities, and those with heart disease, asthma, renal disease, metabolic disease, hematologic disease, and neurologic disease are at higher risk of increased complications from influenza. Certain populations, such as Indigenous Americans, also may be at higher risk of increased complications from influenza. Children under the age of 2 or those at least 65 years of age are also at higher risk of complications, and in general, infants and young children under the age of 3 may be better evaluated in person. Some of these patients may be better evaluated in person to ensure they do not have any signs or symptoms of complications. Patients with severe symptoms should also be evaluated in person. You confirm with this patient that he has no past medical history or belong to any groups that would put him at high risk of exacerbation of a chronic medical condition or at risk of complications. Note that while the influenza vaccine is the most important way of preventing influenza and its complications, patients can have received the vaccine and still contract influenza. Depending on the patient, the vaccine, and its match with circulating strains, the effectiveness of the vaccine can range from approximately 40% to 60%. Even if the vaccine does not prevent someone from developing the flu, it can lessen the severity, which is very important to stress to patients. Ask the patient focused questions to determine if he has altered mental status or shortness of breath, which would require emergency attention, and to see if he has a high fever of over 102 degrees Fahrenheit, which might require an in-person visit. You quickly assess the patient and determine that he has no symptoms of altered mental status or shortness of breath, and his temperature was 101 degrees Fahrenheit. Your patient has no past medical history that would indicate that he may need an in-person evaluation, or signs or symptoms that would warrant an in-person evaluation or emergency department referral. Even if you are using a triage protocol to determine whether patients with symptoms of influenza might be appropriate for telemedicine, the clinician may want to reconfirm these responses. Moment 2 asks, does my patient have signs or symptoms indicating an infection that may require antibiotics? Is a diagnostic test needed? Let's gather some additional history and perform a virtual physical examination. You ask him questions. How long has he had these symptoms? What were his symptoms at the beginning of the illness? And what are his symptoms now? Does he have a headache? And if so, what does it feel like? Has he noticed any wheezing? Does he have a sore throat? Is his cough productive? You've already asked about his temperature. You ask these questions and the patient responds, saying that the symptoms started 2 days ago. There hasn't been much of a change in symptoms over that period of time. He still has myalgias and feels like he has a fever. He also has a mild frontal headache that got better with acetaminophen. He hadn't noticed any shortness of breath or wheezing. He does have a mild sore throat, but is able to drink and eat normally. His cough is dry. He has had a negative COVID test. When you're evaluating a patient via telemedicine, you can perform components of a virtual physical exam with help from the patient. It may be helpful to have the patient or caregiver obtain a spoon, light source, and go to a private room before their appointment starts. Give the patient or caregiver clear instructions about what to do and where to move the camera and the light source, such as on a smartphone, and you can complete many components of a physical exam. Ask your patient to position himself and his camera, as well as any light sources he has available, so that you can first see the inside of his nares, then the inside of his mouth, and finally, perhaps with help from a spoon or other object, the oropharynx. You may need to ask the patient to reposition himself or the camera at different points, so you have as clear a view as possible. You note that his nasal mucosa are pinkish red with no discharge, bleeding, or swelling. His oral mucosa are moist. His oropharynx is erythematous. You can also perform a pulmonary exam. When you're speaking with the person, check for visible dyspnea, increased work of breathing, and whether he's speaking in full sentences. You can also have him remove his shirt if he is in a private location so that you can assess for retractions when breathing. You can measure his respiratory rate by having him place his hands on his shoulders. You can then more easily observe when he takes breaths and count the rate at which you see his shoulders raise and lower. You observe that there is no visible dyspnea or increased work of breathing. He's speaking in full sentences. When you look at his chest, you note no retractions. His respiratory rate is 12 breaths per minute. In a patient with influenza symptoms, the decision to test for influenza depends on the prevalence of influenza and on your patient's risk for complications or hospitalization. If the prevalence of influenza is low and the patient's symptoms are nonspecific, testing for influenza is not necessary because influenza is less likely, and a false positive test may be more likely than a true positive. If there's a high local prevalence of influenza testing may also not be needed, since patients who meet criteria for treatment can sometimes receive empiric therapy over telemedicine. Influenza testing should be considered in circumstances where influenza is not highly prevalent, but if the influenza tests were positive, you would treat the patient. Examples of these include when a high-risk patient, including those with immunocompromising conditions, present with influenza-like illness, pneumonia, or nonspecific respiratory illnesses when influenza is circulating locally. Another example includes patients who present with acute onset of a respiratory condition and either exacerbation of chronic conditions or potential complication of influenza, where influenza is circulating locally, and testing will influence your management. You can also consider testing patients not at high risk for complications who present with influenza-like illness, pneumonia, or nonspecific respiratory illness when influenza is circulating, if you would consider treating the patient with antivirals or providing prophylaxis to household contacts at risk of complications from influenza. You can consider testing patients in whom there's a question about whether they may have COVID or influenza, and in whom treatment decisions may be made for either COVID-19 or influenza based on the results. You can consider testing patients who have symptoms and history that are classic for influenza and the local prevalence is low or unknown. And finally, you can consider testing if there is an acute onset of respiratory symptoms with or without fever, especially if the patient is immunocompromised or at high risk of complications, and influenza is not circulating at a high prevalence. In treating influenza, timing is important. If the patient is highly likely to have influenza, consider treating even without testing. If you are unsure, as we had discussed, and the patient is at risk of complications, you may also want to consider treating even if you can't get a test. However, there may be ways to get tests quickly. Accurate influenza testing requires attention to both specimen collection and test selection. If you have the ability to refer locally for testing, or if you have a physical clinic, this might be an option. The optimal specimen is a nasopharyngeal sample obtained with a flocked swab. Collection requires inserting the swab into the nasal cavity. The specimen should be collected as soon as possible after the onset of illness, preferably within 3 days from the start of symptoms. Consider where you may send patients who require testing for influenza. Practices use 2 types of tests to obtain results: rapid antigen testing and rapid molecular assays. Rapid influenza direct antigen diagnostic tests look for viral antigens. These tests take only 10 to 15 minutes to run, and many are available as point-of-care tests. Most of these tests are specific, around 90%, so if the test is positive, you can generally trust the results. However, the tests are only 50 to 70% sensitive, so they frequently miss cases of influenza. Furthermore, these tests are generally better at detecting influenza A than influenza B. Because rapid influenza antigen tests are not very sensitive, rapid molecular assays, which detect the presence of viral nucleic acids in upper respiratory tract samples, are preferred. These rapid molecular assays are both highly sensitive and highly specific. Some of these rapid molecular assays take as little as 15 to 30 minutes for results to be available, and many are cleared to be used as point-of-care tests in clinics. Note that some, but not all, rapid antigen and molecular tests also detect the presence of RSV or SARS-CoV-2. There are some over-the-counter rapid molecular influenza tests available that patients can purchase and use in the home. Some of these over-the-counter tests test for influenza A and B, as well as other respiratory viruses such as COVID-19. These take up to approximately 30 minutes to run. These are available to your patient performing this test in the home just prior to or at the time of your telemedicine appointment, or having the patient obtain one of these tests shortly after your appointment may be helpful. Besides the rapid tests we just discussed, other molecular tests are more commonly used in the hospital setting. Some allow for detection of other respiratory viral pathogens such as SARS-CoV-2, RSV, adenovirus, rhinovirus, and parainfluenza. However, these tests are not rapid, taking 45 minutes to several hours, and usually have to be conducted in the lab. There's not access to point-of-care testing, and it's important to make a diagnosis of influenza or another respiratory virus, such as an immunocompromised patient with fever. Sending out these tests can be considered. You should determine what influenza test, if any, is available to you in your setting or to your patient in the home so that you know how accurate the test is, as well as how long it takes to get a result and what specimen to collect. Finally, note that viral cultures and influenza serologies do not have a role in the evaluation of patients with an influenza-like illness and should not be sent for the purposes of routine clinical care. Getting back to our patient, his symptoms are highly consistent with influenza during a time when influenza is circulating, and he's had a negative at-home COVID test. You can ask him about who he lives with and what he does for a living. In answering about his family, none of his household contacts are high risk. He does not work in healthcare, so you elect to not have him undergo testing. Let's discuss moment 3. If antibiotics are indicated, what is the narrowest, safest, and shortest regimen I can prescribe? Antibiotics are not indicated to treat uncomplicated influenza in the absence of pneumonia. A small subset of patients may develop a secondary bacterial pneumonia after presenting with influenza. These patients will usually report that they were getting better and then developed new fevers and often worsening dyspnea or cough. If a patient reports these symptoms, they should be evaluated in person. If they sound ill, they should be referred directly to the emergency room. The patient we were talking about doesn't meet criteria for antibiotics. However, we can talk about whether the patient might need antiviral treatment for their influenza. Antiviral medications should be prescribed for children and adults with documented or suspected influenza who are at high risk of complications, regardless of influenza vaccination status. This includes those with severe or progressive illness, no matter how long they've been sick, those with chronic medical conditions or with immunocompromise, children under the age of 2 years, adults 65 years or older, and pregnant women and those within 2 weeks postpartum. While it's best to start the antiviral medications within 48 hours of the onset of symptoms, for patients who are at high risk for influenza complications, antiviral medications should be started as soon as possible, even as late as 5 days after symptom onset. If you can't get an influenza test easily in a patient with suspected influenza and who is at high risk of complications, it is recommended to start treatment anyway. Consider antiviral treatment for adults and children who are household contacts of persons at risk of developing complications from influenza and healthcare workers who care for patients who are at risk of developing complications from influenza. Finally, you can consider treatment for any previously healthy outpatient with confirmed or suspected influenza. Antivirals should be initiated within 48 hours of symptom onset to have a benefit, such as reduced duration of fever and symptoms, reduced likelihood of developing acute otitis media in children, and reduce lower respiratory tract complications or hospitalizations in adults. If initiated within 48 hours of symptom onset, antiviral therapy is expected to reduce the duration of symptoms by 1 to 2 days. There are a few options for antiviral medications. Oral oseltamivir for 5 days can reduce the risk of complications from influenza, including hospital admission in high-risk patients. Oseltamivir can reduce the duration of symptoms by 1 to 2 days in lower-risk patients who are initiated on therapy within 48 hours of symptom onset. Although the U.S. Food and Drug Administration has not approved oseltamivir in children younger than 14 days old, both the Centers for Disease Control and Prevention and the American Academy of Pediatrics recommend the use of oral oseltamivir for the treatment of infants under 14 days of age with the flu. Pregnant women are at high risk of serious complications from influenza, including adverse outcomes to the fetus and maternal mortality. For this reason, while data are limited, oseltamivir is encouraged for the treatment of influenza in pregnancy. The 2018 Infectious Diseases Society of America influenza guidelines recommend inhaled zanamivir for outpatients as an alternative to oseltamivir. The recommended dose is 2 inhalations twice daily for 5 days. Of note, zanamivir is approved in children ages 7 and older. There is a concern for a potential increased risk of bronchospasm with the use of inhaled zanamivir, so for this reason, oseltamivir is preferred in patients with chronic lung disease, such as chronic obstructive pulmonary disease, or COPD, and asthma. However, in a placebo-controlled trial of patients with influenza and mild to moderate asthma, or COPD, inhaled zanamivir was well tolerated. Baloxavir was approved in October 2018 as a single oral dose for otherwise healthy patients 12 years of age and older who have been symptomatic with the flu for less than 2 days. It works differently than other influenza antiviral drugs. It can be particularly helpful if there's known resistance circulating to antiviral drugs like oseltamivir. It may be particularly effective in treatment of influenza B. However, there is a risk of emergence of resistance during treatment, so for this reason, baloxavir is not recommended for treatment in severely immunosuppressed persons, as they may experience prolonged viral replication and therefore resistance. As an additional question, what about people who are exposed to influenza? Should they be given antiviral medications? Patients with a significant immunocompromise and other groups at high risk for complications who are household contacts to someone with influenza should be considered for prophylaxis, especially if they were unable to be vaccinated or it was thought that the vaccine would not be effective. If prophylaxis is administered to high-risk contacts of patients with influenza, it should begin within 48 hours of exposure to the infected individual. Prophylaxis should continue for 7 days after the most recent exposure, with either oseltamivir in those over 3 months of age, or inhaled zanamivir for those at least 5 years of age. Baloxavir can also be used for prophylaxis within 48 hours of exposure as a single dose. Let's get back to our 35-year-old healthy male patient with no concerning signs or symptoms indicating severe disease, who has no household contacts with individuals at high risk of influenza complications and does not work in healthcare. He has had symptoms for 2 days, so it's just at the 48-hour mark where we could potentially get a benefit from antiviral treatment. While guidelines do not recommend for or against treatment in healthy adults, you could consider discussing with him starting oral oseltamivir for 5 days, inhaled zanamivir for 5 days, or 1 dose of oral baloxavir. Now we're at moment 4, which is, what symptomatic relief should I offer or prescribe to my patient? What should I tell my patient about the expected course and the follow-up plan? There is no good evidence for or against the effectiveness of over-the-counter medications for symptom relief in patients with influenza. However, it is important for the patient to rest and stay hydrated while feeling ill. Some medications that may help your patients include acetaminophen, nonsteroidal anti-inflammatory medications, nasal decongestants, oral decongestants, antihistamine decongestant combinations, or antihistamine decongestant analgesic combinations. Albuterol is suggested only for patients with known issues with airflow obstruction. Patients should be aware that they will likely feel ill for a week or more. For the follow-up plan, give them specific reasons to return for an in-person appointment. For example, statements such as the following can be considered. Come for an in-person visit if you develop a persistent high fever, severe headache, pain in your face or forehead, severe fatigue, or a rash. Go to the emergency room if you develop confusion or difficulty breathing or swallowing. These symptoms may be signs of complications from influenza, such as secondary bacterial pneumonia or encephalitis that should be evaluated and treated. Let's say that the following October, the same patient presents for a routine telemedicine appointment. During the visit, he asks you if he should do anything to prevent influenza. You use this as an opportunity to advocate for influenza vaccination. Although you can't provide the influenza vaccination over telemedicine, the patient could present for an in-office appointment or receive the vaccine in an alternative site. Routine annual influenza vaccination is recommended for everyone over the age of 6 months who do not have contraindications. While vaccination is most ideally performed in September or October, vaccination can continue through the influenza season. Children aged between 6 months and 8 years who have not had 2 doses of the influenza vaccine at least 4 weeks apart in the past in the same season, consecutive seasons or non-consecutive seasons, should get 2 doses of the vaccine. But other children and everyone at least 9 years of age only requires 1 dose. Older adults at least 65 years of age should receive a higher dose or an adjuvanted influenza vaccine. There is a live influenza vaccine This should only be given to those between 2 and 49 years of age and should not be used during pregnancy, in patients with immunocompromise, in patients with chronic medical conditions, and in caregivers and contacts, including healthcare workers of patients with severe immunocompromise. And of note, egg allergy is no longer considered a contraindication to influenza vaccination. Let's summarize this presentation. The most important information to know when considering a diagnosis of influenza is whether influenza is present in the patient's community, whether they have been tested for COVID, and whether the patient has typical symptoms. Testing should be considered in patients in whom a positive result would lead to treatment. Critical groups of patients who should be seen in person and treated include those with severe or progressing illness, those with chronic medical conditions, including the immunocompromised, children under age 2 years, adults age 65 years and older, pregnant women, and women within 2 weeks postpartum. Let's talk about what to do next. Sign into the program website, safetyprogramfortelemedicine.org, to review the webinar schedule for upcoming webinars and office hours and watch recordings of past webinars. You've already reviewed this webinar, but just as a reminder, it will be available as a recording as well as a slide set with a script that you can download within 5 days following the second presentation on this topic. You can also review the one-page summaries on influenza intended for clinicians and healthcare workers. Additionally, you can review the sample patient portal scripts for communicating with patients efficiently about influenza. Please also consider using the patient and family education materials. And there is a discussion guide to review with your practice about how you and your practice will manage influenza. Please remember to complete the monthly check-in with your implementation advisor. The deadline to submit your electronic health record or EHR data for March 2024 through August 2024 through the program portal is November 30th. Brick and mortar practices can also submit their MOSOPS data by November 30th. If you're unable to submit your data or have questions, please reach out to your implementation advisor or email the safety program at safetyprogramfortelemedicine@norc.org. Thank you for joining us for our presentation today. We invite you to now ask questions.